So the next session is about the plenary research. So it's around how we can use research for policy. And we have the pleasure to have the 4 coordinators sitting in the panel. So Franco, Nuting, Wolfgang, and Moitza. And I thought I would divide the session in 2 parts. In the first part, I'd like to talk about the data. And the second part, I'd like to talk a little about the evidence for the policy. So on the data, my take is that we really have inadequate data to describe the epidemic of obesity and its risk factor, particularly because we lack the adequate disaggregation. So socioeconomic disaggregation, geographical disaggregation, risk factor dynamics. So let me start by asking Frank whether he agrees on this view. I mean, is that true? Would you agree with this assessment? And what is top done to improve the data? Franco.
Thank you, Francesco. I mean, my answer is, or my feeling is that we're not lacking data. We're not able to gather the data when we need them and for the purposes for which we need them. I think there are some very good examples. For instance, the data the NCD risk collaboration has been gathering, which is one of the resources that the STOP project is leveraging. Essentially, what the NCD risk collaboration is doing is just use data that have been collected by others and that do exist, but simply they're not exploited to the extent to which they could be exploited to generate knowledge that is useful for supporting the development of policies, particularly in obesity and childhood obesity. What the NCD risk collaboration has done is simply, gathered those data from different countries, analyze them in new ways with using statistical models that were not available until a few years ago, and produced estimates and new data that were not available otherwise. So this is exactly what we need to do in many areas. But we also need, linking up with Diane's insights and her talk. We also need a paradigm change in the way we think about data. I think the corporate world, particularly major players in the digital world, have taught us that the kind of data that we've relied upon for a very long time are not perhaps the best data to change people's behavior. So if the goal of governments is to change people's behavior in the direction of improved health outcomes, for instance, the kind of data that we need are not the data that we've been collecting for a long time, which are perhaps very comprehensive, very accurate. But the data that we need, the types of data that those digital players, for instance, are collecting today. These are data on how people actually behave. They're messy data, they're incomplete data. But if analyzed with the right approaches, with the right quantitative techniques, they can provide a lot of information and a lot more useful information about how we can actually influence people's behavior in the direction of achieving the policy goals that governments are pursuing. So this is a new approach that governments will need to take the lead on, rather than just leaving those corporate digital players to own and use the data to their own to serve their own purposes. Governments really need to take ownership of these data and use them in the best possible way.
Thank you, Franco. This is very interesting. So bringing together the data and communicating the data, you already, in a sense, answered the first question of this panel, which is how we collaborate, because we need to have an understanding, a common understanding of what information is available that we that might have an impact on policy, and how to bring them together. Nutinge, I know that Co-Create has been collaborating with the Childhood Obesity Surveillance Initiative in Europe, and you particularly have analyzed the time trends in risk factors for obesity. So, this time trend analysis, has it been useful to guide specific policy developments? And how do you comment also on Franco's point? I mean, can we then use the digital data to also analyze those trends?
Well, thank you. And thank you for bringing up the COSI, the Childhood Obesity Surveillance System. And I should say congratulations to you for that wonderful supplement issue that was published just yesterday. I think that supplement issue really proved the value of COSI data, and also this other pan-European study, the Health Behavior in School Children survey, that also WHO is behind. I think together those, even though of course they do have limitations, they also have a huge value for several reasons. One is what you just pointed to, that it gives us trends on important risk factors, how these change over time in different populations. So that can help us to pinpoint both, are the areas where we see a positive development, and if so, what might some of the mega trends in that area be to support those positive changes, and vice versa, if it is negative changes, what might it be? They also help us to identify subgroups of the population, either age-wise or socioeconomic background, gender, and so forth, that can also help us to really target in on key groups. So, and this is extremely valuable in order to at least have a better idea of what kind of policies and who to target. But there is another value that I want to highlight, and that is because we see that often the evidence base is seen as weak or very weak when it comes to evaluate relevant policy measures. And I think that these two big studies really offer a platform for evaluating studies that have been underutilized. For one reason is that they have already developed validated instruments that has been translated to most languages in Europe. So if there are, for example, natural experiments, we could use these instruments, turn around and do a rapid data collection for larger or smaller groups, supplement with the qualitative data, and then see this as part of a larger picture, because we also have these trend studies. So I think that is a really valuable asset, and that's something we try to capitalize on within the Co-Create project, and linking it to the qualitative data we collect from the young people.
So, Nutinge, you seem to agree that we're doing better with the data, and at least we have the validated instruments. But if we have standardized measures, we can interpret that data. And I was really impressed to see the results that, for example, Portugal has achieved with a 12% reduction in obesity, 10 years in fact in overweight in children. So that's probably good news. And I wonder, Moita, if you want to comment on that. You have been part of European policy initiatives. So is this persuading the policymakers that the direction that, for example, Portugal is making with their policies is the right one? What kind of data do you think are most persuasive for the policy advocacy? Is it the health data, or do we need more economic data, or do we need some personal histories? What do you think?
Yeah, thank you, Francesco, for the question. It is really, really difficult, but I think that at the end, my answer would be that depends on the individual circumstance. But my first comment is, of course, health data, but usually we use disease data, not health data, unfortunately. So when we're speaking about the clinical part of the health in brackets, and then the prevention, we are still with the disease data too much. And if we want to reach other sectors, if we want to reach those who really decide what will be the broader agendas, what will be the funding paths, and the funding opportunities, then we have to start speaking other languages. We have to develop multidisciplinary competencies. And that means that we have to understand other sectors. And I can share here the experience from Slovenia, where we have built a platform with the Institute of Economic Research, Institute of Social Affairs, and our institute, and also Institute for Macroeconomic Analysis of the government, where we are sharing the data. And we have been able to show that together we can do more. We can not even use data in the national context much broadly, and we can reach many more sectors and stakeholders of different sectors with then somehow harmonized messages. But interestingly, it was when we started working together, we used half of a year to understand what we are speaking about, because we had to set the common definitions of the concepts and the data behind. So I think that's this multidisciplinarity and multidisciplinary competencies are really important. Then you can somehow come to the fact also that you have to engage other sciences. It can be even anthropology, as we have seen today, social sciences. It could be all different kind of how to say, in fact, argumentation to which different other sectors or policymakers from the other sectors would listen, because it is their language. It would mean something for them. And I think that quite often we do think too much about the data, in our case, on childhood obesity and on the determinants of the childhood obesity. But we have to some extent also catch the topic that we have to speak also or understand the landscape of the target groups, and we also have from the health promotion, not for the people, but with the people, whatever we do. So here we have moved forward with the data gathering on what would work in specific groups. But what we are doing here in STOP is that we are trying to understand also the landscape of the stakeholders. So it's exactly what Diana was so nicely describing, how important it is that you understand the relations, the concepts behind the trust, the transparency. And I have really got a lot of food for thought here. So that's something that we do not understand just the data about the specific issue, whatever kind of data. It could be health or disease or economic data or statistics or whatever, but that we also understand these processes behind methodologies. It means if we engage with stakeholders, we have to methodologically know how we are going to do it. If we say we are going to do health in all policies, we have to understand what that means and what data do we need if we want to go into these processes. So that's something that we speak about data much broader as just as we are used to do it in the health silos. Thanks, back to you.
Yeah, thank you. So, clearly, here you're saying that the combination of quantitative and qualitative data is really important. And I really hear you when you say that we need to engage with the other sciences to be able to do that and better target our policies. I mean, if we have a good understanding, then our policies would be better targeted. But Wolfgang, talking about policy evaluations, do you agree that having this kind of longitudinal analysis, even if proper evaluation studies have not been decided, may be useful to make us understand the value of policies? Or do you think we need to do more or better designed evaluation studies?
Thank you for this question. I have an echo, which is not easy to answer. The point is that I have the impression over the years that when policies are implemented, when policy interventions are implemented, there's a lack of will to evaluate the effectiveness of these policies. So often interventions have been implemented without a proper plan for its implementation and also for a proper and scientific sound plan for its evaluation. And I think this is the starting point. Before you think about implementing a policy, you should at the same time think about how you can evaluate both the way it's implemented and whether it's implemented effectively, but also its effects on your targets, be it health outcomes or be it health behaviors. So there I see a need of awareness amongst those who are planning interventions, that when they think about interventions, they should at the same time think about the evaluation of these interventions. Often this is done only halfway. Often, if it's done, then it's not equipped with sufficient resources, because evaluation is considered as an appendix rather than a core element of implementation. That's my first point. My second point is, and this relates to what has been said about surveillance like COSI and HBSC. We need these surveillance systems, which are repeated measurements of behaviors and health outcomes in the general population. They are repeated on, let's say, 3 annual basis. So repeated measurements that allow us to assess temporal trends, but also that allow us to assess regional variations. And Knut Inge alluded to this, because this will allow the evaluation of kind of natural experiments. I would say policy interventions are not really natural experiments, but nevertheless, they cannot be evaluated according to the case control or intervention, no intervention design. So we need to use other data, and then the descriptive data of surveillance systems are really helpful. However, and here comes my concern, these data are not harmonized. I mean, the WHO approach tries to harmonize these data, so same methodologies are used in COSI and HBSC across countries, which is really a strong aspect of these 2 systems. However, these are children and adolescents. If it comes to adults, we have a lack of comparable data across Europe, especially when we screened for surveillance systems across Europe, especially in Eastern Europe. So we still need to make an effort to fill the gaps that are there. And there are, for example, in children, gaps in surveilling physical activity data. There is more on nutrition and a lack of data regarding physical activity. So Franco, maybe this sounds like a contradiction to what you've said, because you said we have enough data. I would say we have plenty of data that can be used, could be used more effectively, but there are also data gaps in terms of, for example, very young children below the age of 6. There's a lack of data on physical activity. There's a lack of surveillance data in Eastern Europe. So there's a lot to be done in the future. There are some local national surveillance systems in place, especially in Scandinavia, also in Germany and in the UK. However, they are not harmonized across each other. Even HBSC and COSI are not harmonized. So the indicators they assess are different. The variables they collect are different. The methods they apply are different. So we need a strong effort to harmonize not only the variables and the kind of data we collect, but also the methodologies across systems to make them comparable across Europe. Because this is a great chance for us to better understand whether policies make an effect, because it allows us to exploit the variation that we see across Europe. Third point, these data, these surveillance data, don't tell us anything about causality. They can be used as an argument when there is changes after interventions, but they don't tell us much about causality and the causal pathways leading to obesity. Also, the global burden of disease papers or NCD risk factor collaboration, Franco, these data are descriptive data. They tell us about regional variation, geographical variation, about temporal trends, but they don't tell us much about causality. And we need a better understanding of the causal pathways leading to obesity in childhood, because, and here we have learned, and Diane alluded to this, we have learned that the behaviors themselves cannot be the target. We have to target the upstream factors. So we need to better understand the determinants, to better understand which of the determinants should be approached, which should be targeted, and to identify the most promising targets for intervention. So there is a need for, and you mentioned it, Francesco, there is a need for long-term studies, for population-based long-term international studies in Europe. Unfortunately, the funding schemes that we have are project-oriented, so project durations of 3 to 5 years. I'm talking about projects that have to follow individuals for 10, 20, 30 years. So this goes far beyond the funding logic of the European Commission and also of the national funding agency. And this is a gap, and we miss a chance because we have several baseline data that could be used for such longitudinal studies. So COSI would qualify for this, or HBSC, but it's not done. So here we are wasting our resources, in my view. And finally, and this alludes again to what Franco has said, there are data, and these data could be exploited better, but we don't have the infrastructure for it. For good reasons, I think, but what we would need on a European level is a research data infrastructure. A research data infrastructure that follows the FAIR principle, which means, which enables us to make the data findable, to make the data accessible, to make the data interoperable and reusable in this way. This is the meaning of the word FAIR. And here we need to make an investment, which is not a small investment. It's a big investment that we have to make, because the data we are talking about are individual level data. These are personal data that are highly protected. So I cannot put the surveillance data or other data, cohort data, on a platform on the internet for reuse. So we have to implement measures that, on the one side, ensure privacy of these data and data protection, and at the same time, on the other side, allow reuse of the data, pooling of the data, like the Global Burden or the NCD Risk Collaboration has done. Here, so a clear vote in favor of implementing a research data infrastructure in Europe.
Wonderful, thank you very much to all of you. So the data are there, but they need to be better shared, better communicated, better analyzed, better used. We have some validated instruments, but they're not always used in a more harmonized way. And maybe there's a lot of interesting data through digital platforms that need frameworks to be analyzed. I must say, in WHO, we've been trying to do that, in collaboration with Google Analytics. It's not an easy task, I tell you. But this is telling, giving us some answers about what could be the collaboration. Yeah, we do need some research data infrastructure where data are reusable, interoperable, and can be pooled. So again, it speaks to collaborations, and it speaks to having common understanding about what framework of analysis we might have. Very interesting point about the causal pathways. Not everybody is in agreement with that. I see that Diane say, okay, and then, and what? But, having an idea of the, pathway and the determinants, from, the early causes to the outcomes might help us to identify the process indicators. I do agree that, we need process indicators, but what are the steps that we need to monitor? But actually, this leads me to the second set of questions and to the second part of our conversation, which is on the research to policy nexus. And, if you look at any of the reports that we're doing on policy monitoring, we see that, again, the policies on changing food environment are not largely implemented. And we also have an issue of deciding what are those priorities. You know, member states do not have consensus on that. So WHO, for example, have taken the avenue of developing recommendation and developing systematic reviews on experiences. You know, this is all based on country experiences. Sometimes we don't have enough. Sometimes we don't have the evaluation data to be able to demonstrate that a certain policy is in fact effective. But let me start now from Nuting, because Nuting Co-Create has developed a database of policies. And so my questions are, first of all, how did you decide which policies should be included? And then you also analyzed policies and defined policy benchmarks. So can you tell us what in the analysis of Co-Create is a good policy?
Yes, it's correct. We are developing policy databases, and we have in particular developed one that we call Moving, that try to assess policies relevant for promoting physical activity. And that's linked also with the one that World Cancer Research Fund International already had on diet-related policy called Nourishing. And for each of these policy databases, there is a conceptual framework about policies. And for the Moving, then we try to really identify policies that are relevant for promoting physical activity, say in a school setting, active transportation, green spaces, and so forth. And it's a good question. What is a good policy? We just talked about the data and the individual level data and all the complexities there. And one risk that we have is that we focus too much on the individual level, and that really drives us to kind of individual-based solutions. So one premise that we've taken is that there is a need to look at more upstream factors that will change the environment so that it becomes easier for the individual to make healthy choices. So that's one criteria we have. And then we really have looked at the research literature. What can we detect from the literature about what are sound and promising policies? And then we use expert consultations. So we have really broad consultations with experts in various fields in order to come up with a set of policies that are seen as important and critical. And we include young people as experts to get a broader view. And then we end up with not only focusing on what we think is the best practice, but also having aspirational policy, so that when we do the benchmarking, it is really an aspirational where we think that European countries ought to be. So it's a long process, and we haven't finalized it. We're still in the midst of doing this work, but it is really valuable and worthwhile then to focus more upstream and really focusing on policies, how they are being defined and implemented, and including a broad group of experts, including the young people in that work.
So really the consensus element is there, consensus, including the consensus of the stakeholder. And then I like the concept of aspirational. So that's what the ideal is. But then, you know, what are the factors that make them not, implement it? But let me ask the same question actually to Moitza. Moitza, I mean, you also have been looking at good practices in Best-ReMaP. What is a good policy to you?
Thank you, Francesco. I would say a question for $1 million or something, but I think that Diana has helped us out with this question a bit, because if we are speaking about good practices and good policies, first good practices or best practices, I like the expression good practice if we use this expression, but I like it even more if we speak about the promising practice in complicated and emerging practice, as Diana defined it in her presentation, because there you have a space, she said, for trial and error, which is quite important. And I agree here in the chat with Karin, who said, okay, I think that we have enough data. If we would be waiting for the data and everything would be approved as a good practice, should be in the best practice portal of the EU, then, you know, I can tell you for the Austrian presidency, we have been checking the practices coming from all over the EU, and no one would pass the criteria because they are really, really very restrictive and very high positioned. So for me, it's really important that speaking about best practices and then linked to policies in joint action Best-ReMaP, the member states ran a process of approximately 10 years that we defined the areas for which we think are priorities for all of the member states in which we are going to work to combat childhood obesity, and the complex childhood obesity action plan was adopted in 2014. And from there on, a lot of council conclusions have been adopted. I will be speaking more about that tomorrow. And it has ended up in a Best-ReMaP. And the process of choosing practices for developing the policy measures afterwards in Best-ReMaP was really transparent and very broad, starting from more than 60 practices collected by the member states, and then somehow after voting shrink to 12 of them, and those presented at GRC in Ispra. We had really a very, very intensive few days of presentations and decision making. What could be chosen for the implementation, because we had to choose 3. And speaking honestly about Slovenia, the public procurement practice, which we are sharing with the others, does not have all the elements really defined by the book. Economic impact, for instance, we are doing that, exactly that, together with the OECD now, and we hope that we will come up with good results, because it seems that that is producing the results which we are expecting. But what we did by running the process of connecting health with public administration and public procurement representatives or staff or officers or whatever, how would you call them? That was something what was completely neglected from public health point of view, but there is a huge, huge amount of taxpayers' money at the EU level going into the food provision in public settings. And here we can influence the quality of the foods on a grand scale. So it is a promising something. And it is experimental too. It's emerging from the need that we do something with this in this area. So I think that when you are exploring a practice and you know exactly what policy measure you need, you can try to build it through really thoroughly looking into such practice. And I would say that here we are at the moment quite successful in Best-ReMaP, that 8 of the member states are testing what is happening in procurements. It's approximately 17 which are working in food monitoring, and there we would also like, based on everything what was achieved in Europe till now, including the Nordic protocols of monitoring, we would like to come up with something what would be harmonized at the EU level with the member states. And I think the biggest success is what France is doing, because they have tested their reformulation monitoring in JAMPA and with 3 countries, and now with 21 they are implementing the system at the EU level. So I think that's something where we can speak even about the topic of the Slovene presidency, because the topic for the health sector was innovations in health sector, and the driver behind was that it's not enough to have just a practice and share the practice around. The practice should give something more efficient at the end in the system. So I think, again, I'm going, and I think I will repeat that whenever I'm asked, that we really need a network of the member states. We had it, and it produced very effective outcomes. So you need a strong group of individuals, it was said in the previous presentation, who believe each other, who know what they're doing, and we have had that, and I would really wish to have that back. Thank you so much.
Yeah, thank you, Monica. But it seems to me that we're not dealing with an exact science. I mean, this is the EU policies are not necessarily corresponding to what they're meant to they're designed to do. Then not all the analyses are made by the book. Then we need to find consensus among those who mean well. Yeah, I wonder whether there's a bit more science that can go into these processes. So let me ask actually Wolfgang, because also Penn did policy mapping in collaboration with Informers, which has a lot of experience in policy mapping all over the world. I wonder actually whether you've been able to somehow analyze the context factors and the implementation elements that make the same policy more effective if implemented in a certain way.
Well, we are still underway in doing this analysis, and what we did in Penn was to apply the policy index, the Environment Policy Index for Nutrition, to a number of European countries, complementary actually to what STOP is doing. They use the same approach in other countries, and we harmonize this approach across both projects. Which is informative because it allows us to benchmark policies and to compare national policies to best practice policies. And this has received so far big attention. For example, in Germany, the German Policy Index was published 2 weeks ago and received huge attention because Germany doesn't perform quite well in comparison to other countries with regard to policies like food labeling or healthy nutrition in institutions like schools and kindergartens and so on. The new thing is that we developed or that we are on the way to develop a similar environmental policy index for physical activity, which was missing so far. And this will be the news that we, in the end, hope to be able to assess European policies with regard to the promotion or the support of physical activity. You alluded to the variation that we have and the question of what makes a policy effective. Actually, we are concentrating in case studies on specific policies like sugar taxation or on urban mobility plans to support physical activity. That's the second one that we evaluate. And the third one is on school programs to support healthy nutrition and physical activity. And here we do see European variation, and we hope to benefit from and to learn from it, in which way a taxation operates best or in which way these school programs work best. So they are implemented in different ways and they are designed in different ways in the European Union. And that's, I think, one of the advantages we have when we do these kind of studies on a European scale, because we can compare countries across Europe and exploit the variation that we see in Europe. But I would like to also address some of the thoughts that were raised in the chat, Francesco, if I may, because some of these comments react to my statement on causal pathways. And I must say, when I was talking about causal pathways, I'm not talking about the proximal causes of childhood obesities, where we know a lot, and that boil down to the move more, eat more healthy message, which doesn't work, as we know. But when I talked about pathways, I was referring to the pathways leading to these behaviors, to these health behaviors that are related as and considered as the risk factors. And here we understand much less. There was a huge European program, DEDIPAC, Determinants of Diet and Physical Activity, funded by the Joint Programming Initiative, Healthy Diet for the Healthy Life, JPI, in Europe. And in the end, what came out was, in my view, quite disappointing, regarding the knowledge that we have regarding these causal pathways and the upstream factors leading to these and how they drive these health behaviors. It turned out that for the majority of behaviors that were considered, they boiled down to sex and age, virtually. It's an oversimplification, of course, what I'm saying, but this project really showed the gaps. And when it comes to causal inference and causal inference models, we are working on this in our department, in our institute. These models need data, and they need cohort data, they need longitudinal data, and we don't have these data, at least not in a sufficient way and in sufficient detail to do these analyses. So I'm really advocating for your understanding that you help to support these kind of studies. They are still needed, I'm convinced. Thank you.
Thank you. It's good that you responded to that. Yeah, maybe a last comment I'd like to ask Franco. And this is about the value of cost effectiveness. I mean, this has been something that STOP has been doing, and there's challenges in modeling, but that's a very critical instrument. I haven't heard that a lot from the others. What would you like to add, Franco?
Well, the issue of cost effectiveness in childhood obesity policies or obesity policies more generally is very tricky because many of the policies that we're talking about are really outside of the health sector. We've been talking a lot in the stakeholder engagement sessions about the need for different government departments to come together and develop policy approaches that really cut across government. And when we are discussing the allocation of resources across different government departments, across different sectors of public intervention, the type of cost effectiveness analysis that we're used to in the health sector, it becomes completely irrelevant. So we need different approaches to assessing the economic value of the policies that we've been discussing today. And these approaches are not very widely understood across, as I say, different players in government. So we really need to be able to educate government decision makers to the metrics and the language that is needed to understand the resource implications of and the economic value of the policies that we're discussing here. This work is really something that takes time and a big effort on the part of everyone.
Thank you, Franco. So not just cost effectiveness, but some investment cases needs to be developed for these different areas. Okay, thank you. And I think again this second part is giving us very interesting highlights about how much we know, but also how much we don't know about policies. And the research part is definitely needed. I can tell you that for the work that WHO does, having more structured data about policy evaluation is critical. Having better data on cost effectiveness is critical. If we want to do advocacy at a high level, we need that information. I think this is where the science is needed. Otherwise, we'll have to end up with a consensus. And I can tell you that consensus in the international context is not going to happen. I mean, we always have had pushback, even if it's from a single country, we have had pushback and there's no consensus. So, you end up with basically no real action to be done. So we need to, from the science point of view, be able to indicate the way forward. Thank you very much. It's been a very interesting conversation. Moita, over to you.
Thank you, Francesco, for leading this roundtable on research and how the research can be used in policies. Really, you have highlighted the topics which we wanted to raise up at the conference. So thank you so much. Thanks for all of the colleagues. I have to say that it's an excellent example how a Big Four consortia can work together and how can align the efforts so that we can achieve more in the area of combating childhood obesity.